Is this Dr. Martin?
Yes.
Okay, yeah. So yeah, um, this is from a PDF that was published by the AMC about how the exam is. This is roughly what the examiner's sheet looks like based on AMC. So this is the topic. It's shortness of breath. The name of the candidate or the candidate number is here. So this is the candidate ID cited. So in face-to-face exam, what happens is that as soon as the ring bells, your thinking time finishes, you enter the door, the examiner will greet you and check your ID. And then the examiner is going to ask you whether you've understood your tasks. In online exam, at the beginning of each station, they're going to ask you to say your full name and your candidate number. And you'll have a card so you can show it up on the camera. So this is why they've put it here. They tick this when they confirm our ID. And then we have key steps. So the key steps in the AMC exam are secret. The AMC doesn't publish it. So this is what like a criteria we need to meet as a candidate in the exam. No one knows that for each case what the key steps are. So in the shortness of breath case, the key steps is number 1, inquired about history of recent travel. So this is a key step. In order to pass, you have to ask this question for the shortness of breath case. Even the STEM is shared if you go to the pamphlet. It's on AMC website. There's a STEM that indicates a pulmonary embolism. Number 2 key step is requested measurement of oxygen saturation. This is when we most of us start with hemodynamic stability. So that's also a key step. And number 3, consider the likely diagnosis of pulmonary embolism. So coming up with the correct, most likely diagnosis is a key step in this case as well. Then we go down and this is the domains. So the domains, again, we know roughly what it is. There's an approach to patient for each case. Even in online exam, for the physical exam stations, we have an approach to the patient domain that we are assessed in. Sometimes because the patient is not there in online physical exam, they will assess our approach to the medical student. How much we check the medical student's understanding, how much we engage in the conversation, how much we're open and willing to explain or repeat something. These are part of approach domain. So in the exam, a lot of people think that I've said this before. A lot of candidates think that approach to patient or relative just means that we need to empathize, like sentences like, "Oh, I'm so sorry to hear this. That sounds terrible. I'm sorry that you had to go through this. I'm here to help you as your physician." Yes, these are nice sentences and increase our approach to patient, but it's not just approach is not just limited to empathizing. Addressing patients' concerns, addressing patients' need is a very, very important part of approach. So in a patient with pain, not addressing the pain, not offering pain relief medication marks us down in the approach. In a patient who has a significant concern about financial issues, not offering and not considering that concern, not addressing that concern, will be marked down. So that's also part of approach to the patient. And then we have, so in the explanation, it says demonstrate a respect and empathy towards the patient and use plain language and active listening. So active listening means addressing whatever the patient tells you. if we don't address what we hear from the patient, it means it's not active listening. We're not listening to the patient. And then using layman language is part of the approach. Then we have history. So in the explanation, assess the degree and duration of shortness of breath, previous similar episodes, and any other symptoms such as chest pain, coughing up, phlegm, blood, fever, recent colds or flu, and in the past. So this is, in other terms, just basically asking about, it's technically asking about history of presenting complaint, starting with an open-ended question, asking the proper history of presenting complaint, and asking differential questions. So differential questions, in a case of shortness of breath, we always have to have one or two differentials that are life-threatening. So let's say in a person with shortness of breath, differential diagnosis could be something like an asthma, like a chronic obstructive pulmonary disorder or disease, or a upper respiratory tract infection, or it could be a reflux. So reflux and upper respiratory tract infection, okay, good, acceptable. But even though we have 4 differentials in this shortness of breath, we still might not pass because there are 1 or 2 life-threatening situations that we've missed. 1, pulmonary embolism. 2, like an extreme heart failure or like a myocardial infarction. So 1 or 2 of our differentials needs to be a life-threatening situation that if missed, patient's care is going to be compromised. And then choice of technique of exam, organization, and sequence. This is specifically in PEFE. And in online exam, when we're explaining physical exam, choice and technique, okay, it's important. Anatomical landmarks is important. But both in PEFE and online physical exam, what matters is not jumping from one section to the other. Like general appearance, oh, okay, I remember office test. Oh, let me go back, I forgot the chest. Okay, oh, let me palpate the abdomen. Oh, let me go back, let me auscultate the chest. This is, it really, structure matters, organization matters, so jumping back and forth will mark us down. And then diagnosis and differential. So here it's very, very important that we start our diagnosis and differential task with the most likely diagnosis. Always say that first, and then mention 2 or 3 differentials. That's the general rule of the AMC. So in each domain, N means that we haven't reached the task, meaning that let's say we ran out of time, couldn't mention diagnosis differentials. We get an N. And then 1 to 7 is the grade we're marked on. Again, another thing that is mysterious about AMC and no one knows is that a lot of people might think that they just calculate an average, like let's say it's a 4, 3, 4, 5, 7, and then they just calculate the average and that'll be the global score. That is not correct. The global score is the examiner's general assessment of our performance. So we might get like a 3 and 4, 4, 4. And if we calculate the average, it'll be a 4 or 3.8, but we still might fail. So whether the examiner is the one who decides to round it up downwards or upwards. So we might fail even though in each domain we got like an acceptable 3 or a 4. And in order to pass the case, we have to get 4 and above in global score. So the key steps are a mystery. What the main assessment area is also a mystery. No one knows, because in some cases the history is the main predominant assessment area. In another case, diagnosis might be the predominant assessment area. These are a mystery, no one knows. And how this global score is calculated, again, no one knows. All right. Okay. Now let's go to our psych. Okay. So this is an algorithm. Again, this is just, this is not from any website or anything. This is made by myself. It's just to make things easier. This is just a recommendation, is what I suggest, but by no means I think that there's a right or wrong way. This is just a suggested approach to psychosocial history taking. And I haven't numbered these because on purpose, I didn't number these because it's up to the case and up to the role player and what the role player is saying. It's the physician and the candidate who decides which one to ask first. Okay. So let's break it down to different parts, and then we can go through the rest of it. So the format consists of confidentiality, history of presenting illness or history of presenting complaint. Then we have heads, which will break down. We need to do mood assessment. We need to inquire about anxiety and anxiety-related symptoms. We need to inquire about psychotic features, and we also need to rule out organic causes. And we also have to talk about past medical history and family history. Okay, so confidentiality statement. There are many different ways to talk about confidentiality. We need to stick with the most simple, the shortest one, because the exam has a time limit. There's a time factor. So what's been acceptable for confidentiality statement is just remember whatever we discuss will remain confidential unless there's harm to you or others. There are other parts of confidentiality statement as well, but even in real life, when we want to interview a patient, just saying this is enough. And remember, it's better to stay at the start because the role players in the exam are instructed in a way that they won't open up. If we don't mention confidentiality, they might not open up if we don't start with an open-ended question. And this is why under exam stress, a lot of candidates say, okay, I was asking everything, but they wanted to fail me deliberately because the role player wasn't answering any questions. So whenever you're in the exam and you have a role player that's being difficult to you, try to repeat your open-ended question, try to rephrase your confidentiality statement, try to change your tone, and they'll definitely be more cooperative. And it's better to do, as I mentioned in ops classes as well, it's better to be signposting. Okay, I'm going to ask you a few questions to assess your mental health. Confidentiality, remember whatever we discuss will remain confidential. And last part is consent. Is that okay? So signposting, confidentiality, and consent. Then we have history of presenting complaints. So we don't necessarily have to always start with history of presenting complaint. It's based on what the scenario is. So it's better to ask about onset, what might have triggered it, anything making it better or worse, depending on what the situation is. And if it's a chronic issue, we always need to ask how this has affected your life. So there will be different aspects of life, like work, like sleep, like eating, like relationships, but we have to pick relatively which questions to ask. And then we have heads. So heads is home, education, career, drugs, and social life. So education and career. So again, we are the people who need to figure it out. If it's a man in his 50s, we don't need to ask about education. We ask about what do you do for a living. But in a young individual who's like in the early 20s, let's say, we say, okay, do you study? Do you work? And home situation, how are things at home? It's better to start when we start with an open-ended question, just that open-ended question is enough. The rest of our questions are better to be yes/no questions to save time. So yes, no, or short answer questions. Who do you live with? And do you get along? Are you in good terms? So yes, no questions or short answer questions. And then drugs, so smoking, alcohol, drugs, medication, allergies, and coffee. So coffee, not in every case is relevant, but let's say in an insomnia case, coffee is important. And then social life. Do you still socialize? This is the question we ask. Do you still socialize? Do you have friends? Do you still socialize? Then going to the mood assessment. So one thing that many doctors overlook is that when they ask, let's say the case is a bulimia case. So all of us have seen the recall, and we do the role play and we say, okay, this is the dental caries case. It's definitely the bulimia. And what they do, the mistake they make is that I don't care about whatever she's telling me about her mood. I don't care. I just ask the mood for the sake of it. All I care about is her eating and her the other questions related to the bulimia. But this is a very big mistake. So whenever a patient, this is the rule of this exam. Whenever someone tells us a low mood, whenever we ask how's your mood, and the patient says my mood is low, we can't just skip the rest of the questions. We need to ask for how long. We need to ask AMC caps, which is a mnemonic. Why? Because we want to figure out whether this low mood is an MDD or if it's just a low mood related to another condition. So we need to ask if the patient gives us low mood. Another rule of the exam, whenever a patient tells us, yes, I do drugs, we don't just leave it and proceed with the rest of our questions. We need to ask how much, for how long, when did you start, how dependent are you, did you have to gradually, so we need to assess the dependence. Same goes with alcohol and smoking. If you say, yes, I drink, we don't just leave the drinking in. Maybe this is a problematic drinking. So if we're asking a question, it should be with purpose, and we need to ask the follow-up questions if we're getting anything positive there. This is why many candidates are downmarked, because they're just asked because they've memorized that, okay, this is a psychosocial history case. In my given time, I need to ask mood, I need to ask smoking and alcohol, but they don't care about the answer. So if a patient is having a low mood, we need to ask for how long and the AMC caps to see whether they meet the criteria for MDD. If there's 4 or 5 of them present, no need to ask the rest of it. Why? Because that already makes it an MDD. If there's 5 or more of these present, if there's low mood or anhedonia, and 4 or more of these present, it's already an MDD. No need to ask all of them. Okay, so the whole purpose of this is to figure out whether this is an MDD or not. So whenever there's low mood, we need to ask, have you ever felt the other way around? Again, candidates easily miss this. And then when they reach the differential, when they're trying to say differential, they say, okay, this could be a bipolar. But it doesn't make sense. Why? Because you never asked high mood. You didn't demonstrate in your history taking that you were considering bipolar. So you have to demonstrate that as well. Then there's S for sleep. So the best question for sleep is, again, a short answer or yes, no question. We don't just generically ask, how's your sleep? So the best way is, do you find it, so we can just quickly say, how's your sleep? Do you find it difficult to fall asleep? Do you wake up early in the mornings? Any nightmares, flashbacks, or vivid dreams? These are all yes, no questions. And the how's your sleep we ask initially, we don't want to know the answer of how's your sleep. This is just a way to signpost. Okay, I'm going to ask about your sleep. Do you find it difficult to fall asleep? Do you wake up early in the morning? Any nightmares, flashback, vivid dreams? And we need to ask all of it. Again, a lot of candidates tend to just say, how's your sleep? Do you wake up early in the mornings? And then they just don't care about the rest of the questions. And they easily miss diagnoses like grief. Because in grief, there's vivid dreams. In AMC, one of the positive findings they'll give you for an anniversary grief or for an abnormal grief is vivid dreams. Or they say any nightmares and they say yes, but they don't ask what the nightmares are. Like they don't care. This is why they're downmarked in their approach. So whatever the role player gives you, especially in psych cases, grab it and dig a little bit deeper. Dig into it. You can't just ignore what the role player is saying. Then interest. So how do we ask interest? The shortest way, do you still enjoy the things you used to enjoy? It's a yes, no question. Guilt. Do you blame yourself for anything? Yes. Do others agree with you? Energy. Okay, so energy and concentration, I combine it. I ask, do you have enough energy and are you able to concentrate on your daily activities? So this way I combine these two questions. And in another rule of AMC, asking 2 questions at a time is okay. But more than that, not okay. Whether it's the examiner, they're going to stop you if you ask more than 2 questions. If it's the role player, they're going to stop you as well and slow you down. Then we have appetite. So we don't ask, how's your appetite? We ask, any changes to your appetite? That means overeating or undereating.
Sorry, Dr. Hani, can you repeat the energy and the concentration question again?
Okay. Do you have enough energy and are you able to concentrate on your daily activities?
Thank you.
Psychomotor status. So the way to ask psychomotor status, have you noticed your movements being slower or faster than usual? Suicidal ideation. Have you ever thought about harming yourself or others? Okay. Again, if the answer to this question is a yes, we don't just leave it. We don't just ignore the rest. Okay, we need to assess how far this person has thought into killing herself. So we need to ask, okay, have you come up with a way? And have you planned anything? Have you come up with a way? Have you taken any measures or taken any action? They might be like, yes, doctor, I bought a rope. I want to hang myself. So this means this is different. But have you ever thought of harming yourself? They might be like, yes, I occasionally get thoughts of harming myself, but I've never taken any action on it. or I know that these are just temporary thoughts and I tend to ignore them. So it matters. Okay, so that's how we approach the low mood. Another type is normal mood. So when a patient says, I'm okay, I haven't been feeling down, then we need to ask our screening questions. Suicide is very important. We ask in everyone, regardless of their mood. Sleep is also very important. Again, the same way. How's your sleep? Do you find it difficult to fall asleep? Do you wake up early in the mornings? Any nightmares, flashbacks, or vivid dreams? Guilt we can ask as well. Then we have elevated mood. So elevated mood, we need to ask, have you ever felt the other way around? Because it's two extremes of mood. Distractibility is something we observe, so it's objective. Indiscretion. So the way I like to ask indiscretion is that, okay, Jenny, Jackie, whatever, you said that you've been feeling great. What kind of activities have you been engaging in? Have you been partying, sex, drugs, alcohol, gambling, or any investments? And then grandiosity is also subjective. We need to ask, so do you think you're better than others or have special powers? Flight of ideas is something we assess. Sleep, again, we need to ask. So in all three categories, sleep is important. We always need to ask sleep. And suicide. In all three categories, we need to ask. And being talkative is also objective. We need to observe. Next, we need to ask anxiety. Are you an anxious person? Yes or no? If yes, it's part of the anxiety cluster, which I will discuss in further sessions. Then evidence of psychosis. So we have to be, again, very specific with the psychotic symptoms. So hallucination. How do we ask hallucination? Have you been feeling, hearing, or seeing things that others don't? Then we have delusion. So again, have to be very specific. Do you think anyone's following you or spying on you? Do you think anyone might be trying to harm you? And grandiosity, do you think you're better than others by having special powers? Insight. So a lot of people are like, do you think you need medical help? So this is not the best question. Why? Because someone who's having a somatoform condition might be like, yes, doctor, I think I'm having a heart attack and I do need medical help. That's why I'm here. So the way, again, it's up to you. There's no right or wrong. The way I like to ask it from patients here is I ask, do you think you'll benefit from therapy? Or do you think someone like a psychologist will be able to help you? Then we have cognition. Do you know where you are? Do you know what time of the day it is? And then we have judgment. Judgment is the famous fire Question, if there's a fire in this room, what would you do? And then we have organic. So we have P-type. So it's pain, any trauma. I prefer not to ask any head trauma. So I prefer to ask any previous head injuries. This is the way I like to I like to ask. Infections, I like to ask fever and night sweats. Malignancy, changes in weight. Thyroid, I prefer to ask any changes to your heat or cold tolerance. And always remember to ask perimenopausal symptoms like hot flushes, mood swings, palpitation in perimenopausal women. And any previous medical conditions, any previous mental health issues, or family history of similar issues. Okay, this is the algorithm again. Yep. And this is the cluster. So the questions that have come so far, we have anniversary grief, we have emptiness syndrome, there's adjustment disorder, there is depression, handbook case 131. We have postpartum blue and psychosis, which is handbook case 109. Bipolar is the old recall. I haven't come across any new recalls for bipolar. Yeah. Okay, so one thing, I'm gonna stop sharing my screen for one moment. Everybody else just disappeared again. Any questions about the structure or how to ask the questions? Because now we're gonna jump into role plays.
Hi, Doctor. I do have a question, even though it's not part of the structure of the questions.
Okay.
It's a psychic question. So when we can actually admit a patient under Mental Health Act?
Under Mental Health Act, admit the patient?
Yes.
When there's the patient is usually psychotic and doesn't have capacity or suicidal. I'll talk about high risk in when I teach, when I'm going to discuss the delirium.
Yes.
I'll let you know, but anything. So if you review the algorithm, in the algorithm, the psychotic feature was hallucination, delusion, insight, cognition, and judgment. Any of these being impaired, the patient does not have capacity. So we have to. Plus, if the patient is intact in these areas, but the patient is suicidal, still doesn't have capacity. So we need to admit around Mental Health Act.
What about MDD? Does that advocate for a compulsory admission?
So if the MDD is there, if the MDD they're not hallucinating, they're not delusional, inside cognition judgment is intact, they're not suicidal, there's no involvement with drugs and alcohol, then no, we don't need to. They have capacity. It's just their mood is low.
Got it. Thank you.
Okay. So here what they do is that they form a patient. I don't know how many people are familiar with forming a patient. Does anyone know what that means? When they say a patient is formed. Okay, so when a patient is formed, it means there's a form 1A that they fill out. The form it might be different, might have different names in different parts of Australia, but that means a physician has placed them under the Mental Health Act, and the patient cannot go home or be discharged from any medical facility unless cleared by a senior doctor. So this is when physicians, GPs, or sometimes in nursing homes, the doctors there, or in general practice, the general physician sends the patient to a hospital, and they form them. They attach the form, they upload it online, so everyone would know that this patient is high risk, and they don't let them out of the hospital. So if you're in general practice and you get a patient that doesn't have capacity, you have to form them.
Correct.
So everyone will know, and then when a patient is formed, they will usually have a mental health nurse taking care of them as well.
Yeah.
And even when they're not having any psych issues, if they're formed, it means there's concerns for capacity. So psych team has to review them.
Yeah.
And this is the concerns in the form as well, like any form of psychotic features and suicidal ideation.
Thanks, Doctor.
Very well. All right. So the case that I want to. Okay, I'm gonna share my screen again. Okay, can everyone see the screen?
Yeah.
Okay, who wants to do this case?
I don't mind.
Okay. No one else? Sorry, Dr. Bashir, I would love you to role play. It's just that I'm wondering if you double check.
I'll try the next one.
Right, who wants to do this case?
I can try.
Yeah.
I
Who
don't mind.
wants to do the next one? Okay. Sorry. Sorry, Dr. Bashir, I would love you to role play. It's just that I'm wondering if you double check.
I'll try the next one.
Right, who wants to do this case?
I can try.
Yeah.
I don't mind.
Do the next one. Okay. Why am I hearing myself? Very weird.
We are all hearing each other. The recording is playing back again.
Oh, okay. That's very strange.
Yeah.
Okay.
I wouldn't mind doing the next one, like after the first one, so I get a hang of it, and then I'll try.
Yeah, sure. Okay. All right. Okay, so Dr. Bashir, let me time you. And Okay,
Dr.
please-
Henny, sorry.
No, sorry. Yep. Go ahead.
In the online exam, can we zoom in the screen for like ECGs and pictures? Is there a way to zoom in?
This didn't happen. To be honest, it's quite large. But no, I don't think so. I don't think that's possible in Zoom.
Oh, okay, thank you.
You can ask the invigilator.
Online, there's no one there.
There
Other
is.
than
So in every station you step into,
Yeah?
there's the invigilator that turns the camera and audio off. There's a role player, and
Okay.
then there's the examiner. The examiner is also off and
Okay.
will not respond. But
Okay.
if by any chance, like one in
Yeah.
a million, you need to zoom in or there's a problem, you can just say, can I please ask the invigilator to zoom in? I'm having difficulty to see. They might or might not respond, but don't worry about these things. It's very clear, large fonts, and
Okay.
no issues with these things.
All right, thank you. Thank you
don't
so
worry
much.
about these things. No worries.
All right, thank you.
All righty. So, are you ready?
Yes, doctor.
Okay, please start now.
Good day, I'm Shehan. I'm going to be your GP today. So how would you like me to address you?
Hi, doctor. My name is Matthew.
Hey, Matthew, pleased to meet you. So Matthew, before we proceed, I'd like to show you that everything we do discuss is going to be confidential. I will need to ask you a few questions to understand your condition more. Is that all right with you?
Yeah, that's fine.
All right, Matthew, please tell me what brings you here.
Yeah, I've been feeling different for the past 2 weeks. I'm lost, and I've never felt this way before. I don't know. My counselor was thinking I might be depressed, but I'm not sure what's happening, doctor.
So I'm really sorry to hear that, Matthew. Matthew, please tell me more, like exactly how did this start and what's been going on exactly?
Yeah, doctor. This started 2 weeks ago. I woke up to this notification for my mom's birthday. My phone was telling me it's your mom's birthday, you should text her. And yeah, and since then I just can't focus on anything, and I'm just filled with despair.
I'm really sorry to hear that. So has anything happened to your mom?
Yeah, my mom passed away.
Oh, I'm really sorry to hear that. I'm sure that's not easy. Is there anything I can do to help you about that?
I don't think so, doctor. It's just yeah, she passed away.
So I assure you that, Matthew, I'm going to be doing everything in my hands to help you try to feel better and try to help you go through this. I know it's not going to be easy, but we're going to do all our best to work with each other on this. All right, Matthew, just a few more questions, Matthew. Before this, how did you feel? Were you all right?
I'm doing all right, yeah.
And how are your accomplishments in university generally?
I'm doing well. I'm not the best. I've never been the best, but I'm doing all right.
That's good. That's good. And how are your accommodation?
I live at the hostel, and then I have a few roommates.
And hopefully you're comfortable there and they're friendly with you.
Yeah, we get along. Yeah, we're all busy.
That's good. That's good. And do you participate in any activities as like drugs or alcohol?
I'm a social drinker, but I don't do drugs.
I see. And do you smoke?
No.
Oh, okay, that's good. That's good. Matthew, a few more questions. They might be sounding odd, but they're just questions I must ask you, screening questions. So sometimes when we're feeling a bit off, we might get also a bit down, and we might be thinking about hurting ourselves or others. Have you ever felt like that?
No, doctor.
That's good. That's good. Another thing is, I want to ask you, how generally is your, how is your sleeping?
I haven't been getting the best quality sleep lately.
Do you get any nightmares or difficulty going to sleep? Which part in sleep is you're having problems with?
I wake up frequently.
I see, I see. All right, and in regards to, do you feel guilty about anything about your mother's pass away?
Yeah, I sometimes blame myself for not spending enough time with her.
I can see. That's totally understandable. And uh, what about generally your energy and concentration? Are you able to concentrate on your task, or you can't anymore try to concentrate on them?
Yeah, I can. I still can.
That's good. That's good. Another maybe odd question. Do you see, feel things, or hear things that others don't?
No,
Okay, that's good. That's good. And would you describe yourself generally as an anxious person?
no, I'm not.
That's good. That's good. And have you recently had any, let's say, trauma or something like a hit?
Trauma? Where? To my head? No.
That's good. That's good. All right. And do you feel that maybe you're not able to tolerate changes in weather?
No.
Any
No.
constipation or diarrhea?
No.
That's good. That's good. And do you have any problems generally with like overeating maybe, or
No.
decreased appetite?
No, doctor, it's been the same.
All right, that's good. That's good. And there's been any changes in your weight?
No, it's been the same.
All right. Thank you. I've finished taking history from you. I would like quickly to discuss with you what I'm thinking. So, what I'm thinking that you're going through is something we call anniversary grief. Your mother has passed away and you've got her birthday came across, and that's why you've been going through these symptoms. It's totally normal, and it's not uncommon. Other things I was like thinking of is, could it be that you're going through depression, major depression, but you did not actually suffice with the criteria. So I was also thinking about, could this be also a form of an anxiety? But also it wasn't like you didn't show any, you didn't mention any anxiety generally. Also, other things I was thinking about, could this be like induced psychosis, maybe due to drugs or any alcohol? But also you did deny usage of any drugs, and denied any psychotic symptoms, which are hallucinations. So most likely you're going through is an anniversary grief. It's totally common, and it's very manageable. So I'm going to give you some reading material regarding that, and further manage it with a psychologist.
Okay. Very good. Very good time management. I think you did a great job, but there were like little bits and pieces that I can add, which we will discuss. What do the other doctors think?
Yes, while taking the history of low mood, it wasn't asked, does she feel the other way around? Sorry, does he feel the other way around as well?
He didn't clearly mention, like I didn't clearly say that I'm having low mood. So I think here the screening questions would be enough, even. Because I didn't say that I'm sad, I'm tearful, or I'm really down. I just said that I'm feeling different.
I think you did. At the beginning, you said that the counselor feels I'm feeling really low.
I said I feel lost, and I feel different. I didn't mention I'm sad or low. But he did ask a few questions about, like he did ask the MDD criteria fully. But don't get me wrong, in the exam they might give you low mood, very likely for this case. It's just I didn't give low mood. Yeah. Anything else? Maybe something more like
I'm not sure if
significant here?
when his mother passed away or what happened and like I think the details.
Yes, yes, exactly. So the more common sense questions like, yeah, how did it? So one of the differentials, less likely, I'm not saying a differential here, it could be a PTSD. So just ask, how did she pass away? I might have been like, yeah, we were all in a car crash. I survived. My mom passed away. And I get flashbacks of it. Okay, so that would have been towards PTSD. Okay, so
I'm just wondering, doctor, in cases like this or post-traumatic stress disorder, when you speak about the trigger sometimes, within that might be also like obsessive compulsive diseases. If you do start the trigger, the patient might go through with the trigger all throughout the case scenario. So would it be appropriate actually to discuss that?
yeah,
I just want to clarify.
definitely in this case, because we're the physician and we want to differentiate PTSD. So we need to ask. And in the OCD case, it's different because it's just that word that we shouldn't say.
Yes.
So here, the best way approach is to warn, I'm sorry that I asked, but I'm sorry to remind you of that. But I just need to ask more questions. Can you tell me how your mom passed away? What happened? You did ask how I was doing afterwards, so that's good. This differentiate pathological grief with an anniversary grief. So you did kind of ask how I recovered. So if you asked, I would have said she passed from pancreatic cancer.
Yes.
So, but I might have told you something like it's possible that the role player might tell you, yeah, she passed away in a car crash. So that makes the whole story different.
True.
Another thing is asking about his relation, because it was the mother. So how was your relationship with your mom? How is your relationship with your father at the moment? So if you asked, I would have said I was living with him, but then he moved on and remarried, and now I moved out. I'm at a hostel now, and we're not in good terms anymore. I know it's not very like a critical error, but these are just relevant questions to ask about this scenario.
Yes.
Yep.
Can we ask how's the home situation or something like that? Because I think Dr. Bashir asked about accommodation, so I'm not sure. Yeah, I'm not sure. Like, do we need like how to ask in this case?
Yeah. Are you in touch with your family members, your siblings, your father? Clearly. There's nothing wrong with asking. When you mention confidentiality, you can ask the most personal questions. So, as a physician, because you want to figure things out, you want to help the patient, right? So there's nothing wrong. One thing that I noted here in Australia is that everything is our business. So when I practiced in my home country, a lot of things I didn't ask because it was none of my business and there wasn't much I could do. Even if I wanted to, I couldn't because there weren't adequate social support. There wasn't much I could arrange. But here, a doctor has a lot of power to arrange social support, to call different people, to get help to advocate for the patient. So everything is our business. We can ask the most personal questions and no one's going to be offended as long as we mention the confidentiality statement. So here I've noticed the doctors, the local doctors that practice here ask everything. Like even when they go to the bedside and there's someone present there, they ask, who are you? Are you a friend? Are you family? Are you a parent? Who are you? So everything is our business. We can never say it's none of our business. It's our patient. We need to know everything about it. In the exam, I know it's different. We can't ask everything, but these are relevant questions and it's completely appropriate to ask. All right. And So the positive points that there in the recalls is mother diagnosed with cancer 2 years ago, around the same time, and he's going to say he recovered. So an important question is whether he recovered after mom passed away, whether he recovered, and he'll be like, yes, after a couple of months I recovered. Father remarried, they're not in good terms. Normal mood, disturbed sleep, have a lot of vivid dreams about mom. So here it was diagnosis and differential with reason. So anniversary grief, pathological grief, anniversary grief because your mom's birthday reminded you of your mom, and now you're just feeling different. You're uncomfortable. And differential pathological grief, but that's less likely because you recovered well after your mom passed away. It could be a major depressive disorder, but that's less likely because there's no low mood or anhedonia or loss of interest in daily activity or pleasurable activities. It could be other causes like drug-induced, again, less likely. Could be acute stress. OCD, could just be obsessed by the thought of mom. Could be organic causes, like an infection. And if we're trying to explain what it is, it's a feeling of intense sadness. Anniversary grief is a feeling of intense sadness. It usually occurs during the anniversary of our loved one's death or anything that reminds me of or reminds you of it. It's a normal, expected human psychological behavior. And just for our own information, pathological grief is all the grief symptoms that last for more than 12 months. So that's why I say asking the question whether you recovered well is important. Well, any questions about anniversary grief? Any questions?
So, the anniversary grief, how long does it last? Is it just for like a week or so during that period? Because this patient has got, I think, 2 weeks. So
I've never come across in the DSM I've never come across any timing criteria for anniversary grief.
but the
Normally, we only give the psychological therapy based just for psychologist or cognitive behavioral therapy. Do we anytime need to give any kind of anxiolytics in this one? Because sometimes the anniversary grief can be overwhelming.
So the indication for medication and pharmacotherapy is when there's like either pain or disturbed sleep, low appetite. He didn't have anything. So what he would benefit most from is patient education,
And CBT?
reassurance,
CBT
and
helps?
sorry?
CBT, cognitive behavioral therapy, does it help? No?
And CBT to increase his mindfulness. So no need for pharmacotherapy. Sorry, Dr. Gina, did you get the answer to your question?
yes, I got just another question regarding the pathological grief. It has to be in continuity with death, right? Like more than 12 months since, not like something happened and then the patient.
Exactly. So the thing that differentiates these two is that, so in anniversary grief, one starts feeling the same symptoms of grief, but that's after a recovery. after
Yeah.
a long episode of recovery, just a trigger, and it's not necessarily has to be 12 months or the date of the death or anything like that. Anything like a birthday, tickets to a vacation, seeing their name, seeing a picture of the person who's passed away, anything, any reminder could put them back into the grief phase. That's anniversary grief. But for pathological grief, it's either extreme symptoms or more than one symptoms of grief that lasts more than 12 months. So it has to be when the person dies for continuously for a year. It has to be there. It never goes away. It's pathological grief.
Okay. Sure.
Yeah. Okay. So I think you wanted to do the next case, Dr. Gino?
Oh yes, yes. I thought like you didn't hear me or something. So yeah, that's
Oh,
okay.
no, that's all right. Okay. So can everyone see my screen?
Yes, doctor.
All right. So I'll give you some time to read.
Right.
Okay, Dr. Gina. Sorry, I was a bit late.
Good afternoon.
You
My
ready? Ready?
yeah, I'll just open my video. Just
Okay. Start now.
yeah, all right. Good afternoon. My name is Jane. I'm one of the doctors who'll be looking after you today. How can I address you?
My name is Jackie.
Hi, Jackie. Nice to meet you. I just want to assure you that everything between us today will be confidential unless there is harm to you or anyone else. Is that okay with you?
Yep.
Yeah, sure. So, Jackie, I've read from the notes that you've been feeling down for the past few months. So, can you tell me more about it?
Yeah, doctor, I'm like my world has been like, everything has been different now, and I'm just feeling really lonely, really sad, and I just don't know who I am anymore. I just feel like a useless, lonely person, like a loser.
Oh, I'm really sorry, Jackie, that you feel like that. But can you tell me, is there anything specific happened just before, like, you feel that way?
Yeah, I started feeling this way ever since my daughter moved out.
Oh, yeah. So, why did your daughter moved out?
She went to uni. Me and her father live at a farm, and she's in the city now.
Oh, okay. And do you keep in touch with her?
Yeah, I call her, but she's busy most of the time.
Yeah, I understand them. Like, she must be, but like, yeah. Um, so can you just need to ask you a few more questions just to help you out with this as well. So do you feel like you've got some problems with your sleep? Do you find difficult to initiate sleep or you wake up early?
I find it difficult to fall asleep.
Okay. And do you still interested thing that you are usually interested in?
To be honest, I don't even know what I'm interested in. All my life, I've been looking after my kids and try to be a good housewife, sort everything out for the family. But right now, I just feel useless.
Yeah. But like, is it all because like your daughter moved out, or is there anything else?
It started after my daughter moved out.
Okay, all right. Are you in a good relation with your husband?
To be honest, we're having a lot of arguments these days because I keep asking him to get rid of the farm and so we could move to the city and live with our daughter, but keeps telling me it's not possible, and then we fight a lot over this.
Yeah. Have you tried to visit your daughter or she visits you?
No.
No. Okay. All right. And do you blame yourself, Jackie, for anything?
I do. Sometimes I think that if I was a better mom, my daughter would have stayed with us.
Yeah. And does others agree with you?
No, they keep telling me she's pursuing her dream.
Yeah. Yeah. I understand. And do you have energy to do things and you feel like you concentrate in things that you like your daily activities?
I I think I can do my daily activities.
Okay, that's good. And is there any change to your appetite?
No, it's been the same.
Okay, good. All right. And do you feel like you're doing your activities like more slower or more faster than usual?
No, it's the same.
Okay. Some people like when they are in a difficult situation, they think of harm themselves, or others have been like the situation with you at all?
No.
Okay, all right. Are you an anxious person at all, Jackie?
No, I don't think so.
Okay, all right. And how is sorry. Just a second. So Jackie, you said like you're feeling low after your daughter left the house. So have you been feeling the other way around at all? Like feeling ill or something? No. Okay. All right. And do you drink alcohol every day?
Yeah, I drink a bottle of wine most of the days.
Yeah. Has it been like this from before, or like it started since your daughter left?
It's more since my daughter left.
Okay. Do you feel like you're dependent on alcohol?
Recently, I get really anxious when I don't drink.
Okay, all right. We need to discuss about this because it can affect you in a way, can put some burden on you as well. But we need to discuss it maybe a little bit later, okay?
Okay.
All right. And do you smoke?
I don't.
Okay, all right. Do you take any medication or do you
No.
illegal drugs by any chance?
No.
Okay. Do you have any weather preferences, Jackie?
No, doctor, no.
Do you think that you have any change to your poo or wee or anything like that? Have you had
No.
any trauma?
No.
Any flu-like symptoms, fever?
No.
Okay. Have you, like, when was your last menstrual period?
Like 3 weeks ago?
Okay. Has it been regular?
No, it's slightly irregular.
Okay. Is that been the case lately or always?
Lately.
Okay. All right. Do you get any hot flushes?
No.
Okay. All right. Do you just some screening questions. Do you feel or hear or see any things that others cannot?
No, doctor.
I think the time is over.
Yeah, but you can finish the case. It's all right.
Yeah. And do you feel like anyone is spying on you or no?
No.
All right. Okay. So Jackie, thank you for the history that you've given me. So from the history that you've given me, I think that you have a condition called emptiness syndrome. I'll tell you what this is. It can happen when someone that we used to have living with us and then they leave us. So this is, you feel like you're not, like, you used to look after your daughter and everything, and then she left you. So you feel like lonely and you want to be with her, but like this is life. Like, she needs to go to the uni and she needs to continue her life, and you can visit her definitely, and you can call her and she can visit you in her like holidays, or you can do so. And I was thinking also of major depression disorder, but I've asked you some questions and you did not meet the criteria fully. I was also thinking of some organic causes as well, like maybe changes in the thyroid hormone or trauma or infection. But you denied all other like symptoms that related to that. But we need to do some investigation just to rule out this things. So we'll do thyroid function tests, we'll do full blood examination, and we'll do urea and electrolytes, and we also will do inflammatory markers. This is for the investigation, and then we can arrange for some talk therapy or family meeting with your husband and see what else he can do, or you can arrange with your daughter to see her and be more involved with her. And also you can think about things that you haven't been doing since you've been looking after your daughter. You can enjoy your life, you can go for trips, things that you haven't done before when you were not having enough time for that. And we can consider giving you some medication, but I don't think that you will need that. I can refer you to a psychologist to talk more, and I also can refer you to a psychiatrist, but at this stage I think psychologists would be good. I can give you some reading materials about the condition, and if you felt like you've got any suicidal ideation or anything like that, you have to return back to me straight away. And yeah, are you following with me so far?
Yeah. Okay.
Okay.
Sounds good.
Do you have any questions, Jackie?
No, anything else I need to know?
No, I think if you need to ask anything, just that's it. But otherwise,
yeah, sure. Okay. Thank you.
Thank you.
All right. Good. How long have you been practicing for?
I've been on and off actually. I sat the exam many times.
Ah, okay. You've sat the exam before?
Yeah,
Online or face to face?
both.
Both. Okay. So you've been familiar, and what do you think were your deficits?
Psych.
Psych. Okay. So is it like time management? Is it like
No, I think it was usually like when the role players are difficult. This
was
is
it more difficult in face to face or online?
no, I felt it's more difficult online because sometimes I cannot understand what they're saying, and it's hard to read lips online. And sometimes they can show some accent, like heavy accent as well, especially if like drunk or, you know, some like alcoholic cases or you need this. And they are angry as well. So sometimes I thought that I did well, but like I failed these cases. So not sure.
Okay.
Yeah.
All right. What areas were you mainly marked down on? Was it like approach? Was it the history, diagnosis, or was it just random?
I can't actually remember, but
It's all right. It's all right. I just want to see whether you know what area to focus on or what to improve in.
yeah, no, I'm not quite sure about this, but I
Okay.
I think
That's
it's
all right. It's all right. We'll figure it out. Okay, so here it was just time management. And one thing that I forgot to mention in the structure, here, because there was management, obviously it's best to ask inside cognition and judgment. But if you're running out of time, you can skip those.
which one? Sorry, with
Inside cognition and judgment.
Yeah.
Yeah. I think you did skip.
Yeah.
Yeah, it's all right. It's okay. But yeah, you could have been faster, but it was really good that you asked the trigger. It was really nice that you inquired about the relationship between her and the husband. You did ask, so that was all good. It's just that the pace could have been like you could have been a bit faster.
Yeah.
Yeah. So that's pretty much it. Otherwise, the questions were all asked. Anything the other doctors want to add now?
Yes, you mentioned if she has suicidal ideation, she should come back to you. What do you hope to do when she comes back with suicidal ideation?
Sorry, I didn't get the question.
No, she said that she said when you have suicidal ideation, you should come back to her. So I'm asking, what does she hope to do for her when you come back?
Yeah, this is something we do in the hospital as well, or in GP practice. There's like a pamphlet we give the patients that are at risk, because a lot of people here have chronic suicidal ideation, and that they keep coming to the hospital every time. It's because they're educated to do so. So we usually give them a pamphlet, and it tells them when to come to the hospital or when to reach out for help. And when someone comes with suicidal ideation, if they're at increased risk, it's acute, they're increased active suicidal thoughts, we admit them to psych. That's what we do. But yeah, this is completely relevant to let the patient know that if you start getting thoughts about harming yourself, please seek urgent medical attention. It's relevant to do that.
I think the deficit in my cases last exam was the history. So I got in the two cases, one like 2 in the history and the other was 3 in the history.
Were they psych?
Yeah.
Okay. Do you remember the cases?
Yeah, one was I had my exam in November 21, so it was one cases was a girl just cut herself and had a fight with her roommate, and then
the borderline personality disorder. Yeah, that's a tricky case. Yeah, and what about the other one?
The other one was the man, I think he was in the ED, was brought in by police because he was like hovering around the neighbors.
Was it the schizo relapse case? Was it the schizo relapse case, or was it like a drunk case?
I think it was a drunk case, but like do psychosocial and I think do MSE and present MSE as well.
Yeah,
so.
and was the blood alcohol level given?
I think so.
Yeah, that's a recall. And did you have to assess the alcohol dependence as well? Was that task given as well?
What I've done, I think that's why I got like 2 in the history because
So that case you need to. It's very tricky case, MSE case. We'll discuss it in MSE. You have to ask alcohol dependence questions and take an MSE and then present it. Yeah.
So I got
tricky case.
History in this case and accuracy of examination 3, but the choice of examination and the sequence and everything I got like 5, and the approach I got 6. But yeah,
history was marked out. Yeah, okay, so there must be some key questions that you missed. That's fine. Yeah, that's all right. We'll do the cases together. Okay, so sorry, go ahead.
Can you please speak a bit about border personality? How would it tackle a case of borderline personality?
Yeah, sure. I'll add it to the cases here because in the previous batch it wasn't included. I'll add it to this batch.
Thank you, Doctor.
Yeah, I have to review the recalls myself, but I'll try to include it. It's okay. I'll make sure to include that case. It's a very tricky case, but it's doable. The problem with the exam is those cases that you've revised recently. So most candidates have prepared a lot for the exam, but when they sit the exam, it's just some of the cases they've revised lately, they do them better. Some of the cases they haven't revised for a long time, but they definitely know the case, they've seen the case. So it's very difficult to revise all cases before the exam and remember all the details. That also makes the exam tricky, but it's doable. It's doable. We'll go through this all together. We'll revise everything. So in this case, there's loneliness, feeling empty, losing sense of identity for 4 months after daughter leaving. You extracted all this. And lives with husband in a rural area. I explained all this and you extracted all this. I didn't tell the smoking, but I did mention the drinking, which you did ask about dependence. That's good. And then we have the mood, which you said it's low, and you asked all the relevant questions. But it was lengthy. Could have been done slightly faster.
Okay.
Yeah. So the thing is, you have to have all the questions ready in the top of your head. And when you see the scenario, just in your 2-minute thinking time, try to revise it really fast in your head. Try to think of your differentials. And when you enter the room, just initially you start slow. Open-ended question, listen, active listening, and then quickly just throw out the questions really fast. Yes, no questions, really fast. So differential diagnosis, Of course, emptiness syndrome could be depression. It could be adjustment disorder. It could be anxiety, less likely. Perimenopausal symptoms, hypothyroidism. And then so let me have a look at your task again. Possible diagnosis and management. So what you have is most likely emptiness syndrome. I'll explain to you what that is. It could also be a major depressive disorder. It could be due to anxiety. It could be adjustment disorder. It could be due to perimenopausal symptoms or endocrine causes like hypothyroidism, which is underactive thyroid. What I'm going to do for you now, I'm going to arrange some blood tests. So never skip investigations. Investigations is part of management. So I'm going to arrange some blood tests for you. Then I'm going to give you some reading material. Lifestyle modification is important. Try to make a list of all the things you wanted to do but couldn't accomplish because of your responsibilities. Try to pursue your hobbies. Try to keep in touch with your family. I can arrange a family meeting so you can come back with your husband.
Doctor?
Yeah.
Can I ask over here regarding the investigations, like empty cat nest syndrome, or let's say depression, or let's say like sometimes investigation doesn't really make much or any difference maybe in the diagnosis. Like in this case,
It
empty nest
does.
syndrome, like it depends.
It
Like
does.
depression, maybe thyroid can help, but
Yeah.
in case of empty nest syndrome, how would it really help us?
When it's a low mood, why wouldn't it help us? So this is the rule. Even in an eating disorder case, we have to always rule out. Otherwise, we can't even refer to a psychologist, so psychiatrist. So in order for us to define anyone as a psych case, we have to rule out organic symptoms. It's not an emptiness syndrome. The scenario looks like an emptiness syndrome, but it won't be an emptiness syndrome unless organic causes are ruled out. This is a lady who's presenting with low mood. Okay, based on her history, emptiness syndrome is a very, very likely diagnosis. But just by looking at it and talking to her, we can't confirm that this is an emptiness syndrome. So we need to do blood investigations. And even when you look at the DSM criteria, it always says the symptoms should not be justified by any organic causes. So we need to confirm it by doing blood tests.
I do understand that generally we should rule out other diagnoses, like in depression, thyroid condition is very important to rule out. But over here in emptiness syndrome, I'm not sure would it really be
It's not
helpful.
emptiness syndrome, Dr. Bashir. It's a lady presenting with low mood. She has low mood. She has sleep disturbances. She has disturbed sleep. She has low depressed mood. We need to rule out organic causes.
All right, thank you, doctor.
Okay. Yeah, it's not a confirmed emptiness syndrome.
Yes.
You say it's emptiness syndrome because you've seen the recall and the findings based on the findings I shared with you, right? But you can never confirm it. This is why in the exam, whenever we explain the diagnosis, which is usually our final task, we start with this phrase, most likely. Why do we say it? Because it's not confirmed without investigations. We've only taken history or max to max done a PFE.
Yes.
Yep, so it's a lady with low mood, so we need to confirm. And even in the hospital, when someone presents with like something completely psych, we still need to do bloods and investigations. And then when all come back as normal, we refer them to the psych liaison nurses to review them, or the psych registrar to come and review them. So we always need to do bloods, even when it sounds like completely irrelevant.
Thank you, doctor.
Okay, so yeah, so in management we need to give reading material about lifestyle modification, about sleep hygiene because she had disturbed sleep. We need to address the fact that she has some issues with her husband. And you can then talk about the rest of, in the remaining of your time, you need to talk about like try to engage in your hobbies, try to get in touch with your daughter through social media, video calls, call her more often, visit her, as you said, Dr. Gina. And here, the sleep issue is there, and we need to address the alcohol as well, which you did. So here it's not very severe. She wouldn't need pharmacotherapy. She will need just some reassurance education regarding sleep hygiene. So that will be enough.
Ma'am, I have one doubt. Like it is different from adjustment disorder, this emptiness syndrome. Like what is the differentiation between emptiness syndrome and adjustment disorder?
So adjustment disorder presents with mood or low mood or anxiety. It's very back to back, I know, but the scenario is different because in adjustment disorder, it's usually a difficulty coping. I understand. In this case, there's also difficulty coping, but the loneliness is the main loneliness, the loss of identity makes the scale like heavier. There's no clear-cut differentiation. It's just that it's just heavier on the side of for emptiness syndrome because it says I'm lonely. But if on the other hand, this case would have been like, there's a lot happening in my life. My daughter has moved out. I have to do extra shifts with my work. My husband's not supportive. No one's supporting me. I'm overwhelmed. I can't cope with this whole scenario. That would be more in favor of adjustment. But in this case, it's just a lady. There's not much happening in her life. She's lonely, clearly because her daughter moved out. This is more in favor of empty nest syndrome. Yeah, I know this could also be a coping difficulty as well, going towards adjustment, but it's common sense when we are weighing in the factors from empty nest syndrome versus adjustment disorder. It's more in favor of empty nest syndrome, clearly. Whereas in adjustment, you'll hear things like, I can't cope, I'm overwhelmed, there's a lot happening in my life, I lack support. And it's more like a mixture of mood, low mood, and anxiety. Here, this lady is not anxious. And when Gina asked, I clearly told her I'm not anxious.
Is there any time frame?
Sorry?
Is there any time frame for adjustment disorder?
Yes, it's. I'll explain in anxiety issues. It's usually 3 months since the onset of symptoms, or since the trigger, or since if it's an ongoing trigger, it might be more. But the DSM criteria says 3 months from the trigger. But it's not. That's not always the case because sometimes the trigger is a continuous trigger. Was I able to answer your question, Dr. Martin?
Yes, thank you.
No worries. So Dr. Manjula asked a question here. Don't we need to do physical exam in psych cases? No. As in, you mean recall or just in basics of medicine? Like we do need to in real life as a physician. But in an exam, I haven't seen any recalls where we had to do physical exam in psych cases. Our physical exam, our exam or assessment, yeah, No, the exam for psych is MSE, mental state exam. We don't do physical exam, psych. Alright. Okay, so we have, yeah, let's do the last case and finish mood. So next time we can do other cases. All right, there's one more case left. Who wants to do the next case? Oh, actually, there's more than one case left. There's two more cases left. Anyone? Any volunteers? No one?
Yes, sir. Let me try.
Okay, Tinder?
Yeah.
Yeah, all right. Okay. I don't think we can do the fourth case because it's gonna get really late. This is going to be the last case for today. Please read the case.
Hello. Hello.
Okay, are you ready?
Yeah. Yes.
Please start.
Okay. Hi, I'm Jinder Passing, the doctor today at the clinic. So how can I address?
Yeah, my name is Melanie.
Yeah, I'm Melanie. Yeah, I'm looking from the notes that you're having a issue actually because there had been a problem with you at your workplace, and since few months, you're having such a problem. You're having a problem, and you have been asked by your husband to take an appointment with the doctor, understand something is going on. So let me ask you some of the questions why you're having the problem and how can I help you. So whatever information you're sharing me, that will remain confidential between us. So how does it sound to you?
Yeah, that's all right.
That's good. Okay, can you tell me more about it? What's happening with you now?
Yeah, it's just that I think I'm not a good lawyer and I just think my life is over and I should die.
Oh, I'm sorry to hear that. Okay. So do you still feel like means harming yourself?
Yeah,
Have you tried it?
yeah.
What actually you did of harming yourself?
I was thinking about overdosing with Panadol.
Oh, and do you have an access to it at your home?
Yeah, I just bought like a lot of tablets and then my husband found it and
I'm sorry to hear
booked
that.
an appointment.
Yeah. So how do you find your mood basically? Is it too sad basically, or you feel over the edge sometimes also?
I'm just very sad.
Do you feel like guilty about the thing? Is about anything basically, also about the incident which happened yes in the past?
I am. I think I couldn't. I was incompetent, and that's why our firm lost the lawsuit, and now they had to downsize, and a lot of people and families are just a lot of like providers for their families and employees are just they're unemployed. The company had to downsize, went bankrupt because of me, and then it's all my fault.
Yeah. Are you able to sleep, have a sleep, good sleep, and you are able to concentrate on your things, daily activities?
I can't sleep.
And you have been starting on some medications. So why did you are you taking now, or you have just stopped it?
I stopped them.
Did you any kind of a side effect due to those medications?
No, it's just they weren't helping.
Oh, they weren't helping. Okay. Okay. Now I need to ask you some of the sensitive questions. It's just that, but it's very routine questions I need to ask you. Do you feel, hear, or see things which others don't?
Yeah, I do hear people whispering, and they're telling me I'm useless.
Okay. And also, do you think someone is trying to follow you or harm you?
No.
Okay. Do you feel someone your thoughts have been inserted in your mind, or your thoughts have been taken away from your mind? Anything like that?
No, doctor.
Do you feel like your thoughts are being broadcasted on the social media? Anything like
No.
that? Okay. Do you feel like you're also like the others' actions are being directed towards you, basically?
Sorry?
Others' actions or behaviors are being directed towards you?
No.
Okay. Okay. Do you feel like you need a professional help?
I just want to die.
Also, because do you just suppose if there is a fire in this room, what you will do?
Try to put it out because I don't want anyone else to die.
Okay. Do you take any smoking, alcohol, any drugs you have taken?
I don't smoke. I sometimes drink.
Okay, and how much is it? How much do you take?
Like a couple of cans of beer every night.
Okay. And do you have the family history of the mental problems? Any issues?
No.
Okay. Do you have any past medical history of hypertension, diabetes, thyroid, anything like that?
No.
Okay. And how's your bowel preferences and your weather motions? Bowel motions and the weather preferences?
They're the same.
Okay. Did you had any kind of an infection, any trauma? Do you have had anything like that?
No.
Okay. And do you have how your menses basically? Do you have any problem with your menses?
No, they're the same.
That's it. Thank you. Thank you, Kelvin, for the information what you have provided me. So based on the things, the condition you are suffering from at present is actually a major depressive episode. So you have been having it since a long time now, but you still have this major depressive. Why is it I'm saying? Because you have been put on some of the medications. You had been put on some of the medications before, like which was SSRI, just to reduce basically the sensitivity towards the triggering factor which you had the problem. Okay. But actually, just took the medications for 2 weeks only. So normally, the antidepressant medications do take times around 4 to 6 weeks to act. Okay, are you getting my point until now?
Yeah.
Yeah. So the condition which you have, it's that because it's going on through your mind, disturbing your sleep. You have a suicidal idea. So, but for this, I need to admit you. Do you understand why is it?
Okay.
Yeah, I need to admit you a hospital because you're still saying because you told me like you have an access to the Panadol tablet, you want to take in an excess and you want to end up your life. So for that, I need to admit you to hospital. So I'll be referring you to the hospital where you admitted. You will be seen by the psychiatrist and also multidisciplinary, by the GP also, by the other social workers also, and also by the psychologist who will help you with the cognitive behavioral therapies also. That is actually to understand what your problem is going on, to help you cope up with the conditions, and to make up your mind that how you can fight with those conditions. Okay. Yeah. So there could have been other cases also, like differential diagnosis, like any adjustment disorder and other stuff. Oh, the time is over. So sorry, I went into management. I thought
yes, you were.
it was actually the differential diagnosis.
Yeah,
I thought it was
that's a
management.
very cheap way to lose the differentials, because differential was part of your task, but management wasn't.
Yeah,
And you could easily
actually,
finish
someone
the
came in
task.
between. I suddenly my mind skipped because some patient came, so then I was in the clinic only for that.
Yeah.
So this has been off.
It's all right. It's all right. But yeah, just be mindful. Yes, keep an eye on your tasks. And okay, that was good. Just my honest feedback to you. You know the structure very well, and you know you know what to say and how to address, how to approach the case. That's very nice. But try to just act a little bit of acting. I know we're not actors, we're doctors. We're not supposed to act, but try to appear a bit more empathizing.
Empathetic, yeah, empathetic.
Yeah, just a little bit of more acting, playing with your tone. Like when I said I want to die, just lower your voice, saying it must be terrible. I'm sorry that you're going through this. I'll be here to help you. Just using sentences like this help, because otherwise, as a doctor, you're clearly not indifferent to your patient and you care about your patient. It's just for this exam, you have to demonstrate it.
Yeah.
And this is how we demonstrate in this artificial setting, in the exam setting. Yeah, that's the thing. Yes, Dr. Varin, yes, when there's positive answer to blame, it's better to ask, do others agree with you? Yeah. So in the exam, we don't want to appear like we don't care and we just want to ask our questions and get our history done and finish our case. We actually want to be a caring physician who advocates for the patient and is genuinely trying to help the patient. So we just need to demonstrate this. That's just the feedback I had for you. Another feedback is this lady had hallucination, so it's important that when we mention the
you said something like that is as a persecution, what you call it, persecutory ideas, basically, just to harm yourself, basically. Persecutory.
No, she had auditory hallucinations.
Yeah.
So the point the thing I want to say is that it's important to say it's major depressive disorder with psychotic features.
Yeah, with the psychotic features, yes.
Yes. So don't. It's very easy to forget that. Mention that as well, and yeah, and don't talk about management when you're not asked to. If you have extra time, it's okay. I would personally say, even if you have extra time, better not go through something that's not part of your task. But differential diagnosis and differential.
Yeah, it's actually, it will be major depression. It could be anxiety, adjustment disorder. It could be
it could be acute psychosis. She's having
acute psychosis. Acute
psychosis, drug-induced psychosis, even though.
Yeah, and other organic causes could be thyroid, but we need to.
Yeah, organic as well.
Hypothyroidism also. So that.
Yeah, so when there's hallucination and low mood and suicidal ideation, it's very straightforward, and we can come up with differentials. It's not very difficult. So, and when you say with reason, it's better to talk about criteria of MDD as well, just for MDD, not for other psych issues. For MDD, we're expected to talk a little bit about the criteria. So you've had these thoughts for more than 2 weeks. You're having low mood. You're not engaging in pleasurable activities. You have self-blame. So you have these symptoms.
So basically, she had 5 criteria actually to complete the MDD disorder.
Yeah. So you meet the criteria. That's why I believe you most likely have a major depressive disorder. I was also thinking about adjustment disorder, but this is less likely. I think you're more depressed rather than having a coping difficulty. I was also thinking about acute psychosis because you're hearing things that others don't. I was also thinking about organic issues, but you didn't have any weather preferences or changes to your bowel habits or any changes to your menses, so that makes it less likely. It could be schizophreniform, again, because of the hallucination.
But did you share any kind of other symptoms of the hallucinations?
Oh, no. It just has a differential.
Schizophrenia.
Yeah, just as a differential, nothing wrong. So this patient might be very tearful, might cry. There's another recall that's similar to this. It's just a nurse, and some patient of her dies because of pneumonia and presents with the same scenario. And yeah, these are, just make sure you mention MDD with psychosis, talk about the criteria. It could be you can mention bipolar as a differential because
I asked actually, do you feel over the edge sometimes? So
yes, you did ask. So when you're talking about differentials, you can mention it. It could be post-traumatic stress disorder, especially for the nurse one, if he's witnessed something traumatic, that could be, we can still mention it. A schizophreniform, acute psychosis, delusional disorder, if she's delusional because of the delusion of guilt, and organic as well. So, any questions about this case? Anyone? Any questions? No? Okay, so for next session, we'll do one case is left from mood disorder, which we'll practice. And then we go on and do MSE. Does everyone agree with MSE? Would everyone like to do MSE?
No, ma'am, that's very necessary also because mostly people are getting the MSc question 1. They are most of the patients. In February and March, many people have got the MSCs.
Yeah, so about the borderline personality disorder, the case is a young girl, 19 or 20-year-old girl who has an argument with her roommate, and she's gonna cut herself, and that's why she's here. The case final diagnosis is usually borderline personality disorder with delayed PTSD, because when you ask her, she's gonna say that the argument was about the color pink. My roommate was wearing pink, and I told her to change it. She didn't, and we fell into the argument. So the thing is, you need to ask them, you need to ask the patient, why did you cut yourself? Did you do it? What was the intention? Did you do it to end your life? Did you do it to get attention or send a message? And she's going to say, yes, I just did it for attention, or or she might say, I wanted my roommate to feel bad. Then you have to ask, why the color pink? And she's going to say, yes, I was abused as a child, something along this line. When I was a child and I was wearing a pink dress and I was abused, something along this line. So this is how we figure out it's probably a delayed PTSD. And then the same structure, you need to inquire about the mood, you need to inquire about the relationships. Someone with borderline personality disorder, they have a lot of fights with different people. They have a lot of relationships, a lot of breakups, a lot of friendships that are not sustained. So asking about their relationship with others, their friendships, their personal, intimate relationships, My love life is important is very helpful. What else that I can remember from this case? Substance abuse, asking about substance abuse is important. Asking about previous attempts, previous self-harm, that's also important. And the rest is the same structure as the rest of the psychosocial history taking. It's just that these questions are the most important ones to ask. So, do you lose your temper easily? These are the questions for borderline. Do you lose your temper easily? Do you get into fights easily? And asking about friendships and relationships is also important and helpful in this case. Any specific questions that you have? We'll go through the structure, but if you want to know anything in specific about this case.
So, doctor, the thing is, like a borderline personality, what's a bit difficult, that it's not always apparent that the patient is changing from mood to mood and very moody. So I'm not sure how I'm going to detect that, because if the role player did give it to you and showed you some change in mood and jump in ideas, then it's apparent. But if he didn't, how can you really detect?
They're not going to show the moodiness. So that's why I'm saying it's very important to ask about their relationships.
Like they have actually borderline people have a feeling of emptiness, actually being left alone by the other people, so they have a very unstable relationships.
Yeah, asking about relationships. So there's another recall other than this self-harm one. There's another recall that a girl tries to is brought to you after a suicide attempt to drown herself, I think. And then she did it after the boyfriend broke up with her. And that's also a borderline personality disorder case. With delayed PTSD. Yes, because when you ask why, it's a combined case. Because when you ask why she had an argument, first you ask why you cut yourself, she's going to say, I had an argument with my roommate. Then you ask, what was the argument about? She's going to tell you, my roommate was wearing pink. I hate the color pink. I told her to change. She said that she won't. And that's how we fell into an argument. She left and I started cutting myself. So, so you need to first talk about the cutting, whether she's done it before, what's the intention, was she trying to end her life, or was she trying to send a message or get attention? And then you have to talk about the pink, because that's unusual. So you need to talk about the pink, and she's going to say, I was abused when I was wearing pink as a child, this age. And then she's going to give you things like nightmares, flashbacks. She's avoiding family. She's avoiding the household in which she was molested. So it's combined. She's borderline personality disorder with delayed PTSD. No worries. All good. Any other questions? But yeah, the key to this borderline personality is other than the self-cutting, is the unstable relationships. They have a lot of like ex-boyfriends or ex-girlfriends, and every time they go through a breakup, they just do a lot of self-harm. Very attention-seeking. It's either love or hate, black or white for them. There's no gray zone. But within the limits of the exam, just ask about their friendships and relationships, whether they lose their temper easily, whether they get into fights and arguments easily.
And with all of this, do we ask as well about like the question of the psychosis, the organic and anxiety, the mood, and like all other questions, right?
Yeah. Yeah, we need to ask all that. Confidentiality, history of presenting complaint includes all the questions about the cutting, all the questions about the pink, and then by now we get a sense, okay, this is borderline, so let me confirm it. How's your relation? Let me confirm it. How's your relationships? How's your love life? Are you in a steady relationship? They're gonna say no. And then we're gonna, okay, how's your mood been? And then the rest of the questions based on the structure.
Doctor, just one more thing. In psychic cases, like when we have a female generally, and it's clear that this is psychic case, as previous, the patient's feeling down or suicidal, do we also have to ask about the 5 Ps generally? Or I think it's
not 5 Ps. Oh no, gosh, no. You'll never finish.
Exactly, that's what I'm thinking. So
just ask about, just quickly ask about the periods, and if they say anything, which they won't, if they say yes, it's like irregular or like anything in favor of a gynae issue, then you inquire. But then if it's just like an acceptable answer, like, yeah, it's always been regular, but like in a 48-year-old female, she says, well, recently it's become irregular. Okay, it's nothing wrong with that. It's clearly perimenopausal.
Thank you, Doctor.
Oh, you don't need, no. Yep. All good? No questions?
Sorry, there's something you said, I didn't quite get that in the mood. You said also ask the other way around. What does that really mean?
Yeah, it means that, okay, so someone who comes with a low mood says, Doctor, I feel really sad and I started feeling this way in the past 2 weeks. You have to ask, have you ever felt the other way around, meaning like extremely happy? That's for bipolar. Or when someone who says, Doctor, I'm excellent, I feel it never felt better than this, it's just my counselor, uni counselor has sent me to see you. So you say, okay, it's wonderful that you're feeling great, but have you felt the other way around, like feeling really down? That's again for bipolar.
Okay, thank you.
No worries. Yep, okay. I guess we can call it the night, perhaps? And I think our next session is going to be the
15th, on 15th and 16th.
Yes, correct. Yep. And then for the 4th session, I'll let Dr. Shariar know, but I'm not sure myself. All right. Good.
Thank you.
No worries. I hope you enjoy the rest of your week.
Thank you.
And yeah, see you on Saturday, the 15th.
You too, Doc. Have a good week. Thank you.
Bye.
Oh, good. Thank you.
Bye.
Thank you, Doctor.